Committee, and I.
The broadcast is now starting. All attendees are in listen-only mode.
So I get the pleasure of introducing him. A couple of folks that we had a hangout. Okay, I'll do it. Take on all right. Just a couple of notes. There's one restroom here, but there's also another bank of restrooms. If you go back into the waiting area, you'll feel like, am I at a children's doctor's office? And you kind of are, so just walk through there, and then there's another bank of bathrooms that way. This is being recorded, and so for all of you who find it very interesting, you want to share the information with your friends and family, you can send them the YouTube link. It will give you a reference presentation and the slides, and we'll post that on the site afterwards. So I'm going to introduce Weston. Weston Merrick who leads an initiative to conduct benefit cost analysis of corrections and human services programs for Minnesota Management and Budget. And this program in particular, Results First, is a partnership of the state of Minnesota through Charitable Trust and the MacArthur Foundation. And Weston will talk a little bit more about that, but it's not just the state of Minnesota doing this, it's sort of the state of Minnesota participating in a much larger network of efforts that are happening. Weston advocates for the use of rigorous evidence in defining what works to drive public sector investments, and that's really the driver behind this effort here. And in a previous life, Weston conducted research and evaluation of business incentives and workforce development programs for CDH. Weston and I both hold a rare distinction within state of Minnesota government that neither of us went to. I don't think but if you did, that's fine. We love the Humphrey. It's wonderful. But just to share that Weston went to received his Master's in Public Affairs from Indiana University and holds a BSBA. Didn't realize it existed. All right, BSBA in Finance and Econ from the University of Missouri, where he comes from originally. So please welcome Weston.
So here to talk about Results First today. A couple of notes. Jane mentioned the handout. We're going to be also talking about a full report that is longer, much longer, and is on our website, which you'll see at the bottom of the slides and also the bottom of the handout. There is also an inventory that's on our website as well, and we'll also share. And very soon we're going to be having some Tableau business up there, so check it out. As Jane mentioned, this comes from a legislative request. The legislature in 2015 instructed Minnesota Management and Budget to do benefit cost analyses for corrections and human services programs, part of a broader initiative led by the Pew Charitable Trust and MacArthur Foundation. Right now, they're operating in 24 states doing this form of analysis, though I will say that Minnesota is one of the leading states on the human services end of these sorts of analyses. But to be clear, I'm state employee. The legislature funded some positions for us. This is an initiative that is ongoing and continuous. We'll be continuing into new programmatic areas and every couple of years refreshing the data as well. So what is Results First and what are we trying to accomplish? When Pew started this about 6 or 7 years ago, they were going into states and trying to drive the increase in evidence-based policymaking. And they started to see some common threads of data that decision makers was lacking, and we found those same things here in Minnesota over the last about 14, 15 months that we've been working. They come in three main streams. One, we would go into jurisdictions, counties, or speaking to the state overall, and we were never able to find a completely ready inventory of all the services that we were offering. What are we doing in adult mental health? What are we doing in adult corrections? What are we offering? And how does that compare to what the evidence base is? Number two, what are those services cost? For anybody in mental health or really any direct service provision, do you know how difficult it is to actually say what it costs on a per person basis? There are streams from the federal government, there are streams from the state, there are grants from the state and from nonprofits, there are county tax dollars that are poured into this funding these services. What does it cost on a per person basis? And if we were to add one person or 10 people or 1,000 people to this service, what would it cost the state to do that? Or what would it cost the county to do that? And then 3, and most acutely, we all know as analysts, and there are a lot of analysts in the room, of course, we have a lot of information about output, how many things we do, how many clients we send through a service, how many individuals we serve, maybe the big general idea of how many dollars that we spend. But we very rarely have information on what are the effects that we would anticipate if we deliver a service correctly. What are the outcomes? Do we see declines in hospitalization, or increases in employment, or declines in psychiatric symptoms, or declines in crime if we do these services well? And even more powerful, can we say that there's a causal impact of these services on a client's well-being? So implicit in that goal is we're here to make benefit cost estimates that are good, trusted, and used by policymakers. Our official charges at the state level, the more and more we got into this, we realized that with human services and corrections delivery, there's an abundance of opportunities to drive better decision making at the local level. So we're working there as well to tailor results for counties and for providers and for foundations. Our areas are corrections and human services. In December, we released reports on adult corrections and adult mental health. All those are available on our website. I'm going to focus on adult mental health today. I think, given our setting, that we're at Wilder, that seemed appropriate. But we have full results on corrections. They're similar, but they are a little bit different as well. We've just kicked off work looking at substance use disorder, working with DHS and counties and other folks to analyze the services that we're offering. In the future, we're going to be moving into juvenile justice, children's welfare, children's mental health, prevention services, and a range of other programmatic areas. Now, I think we'll all argue that it's very hard to look at these things in isolation, that there is a whole human approach, and that mental health and substance use and corrections are all incredibly linked together. We agree, and we try and form those connections between the services, but to make this into manageable bits, we do break it into programmatic areas. This is our advisory committee, 3 commissioners from the relevant agencies, 3 senators, 3 reps, 3 GOP, 3 DFL. We're adding a member. We had a member not run for re-election, so we'll be adding someone soon. Representative from the judicial branch and county representatives representing the administrators and commissioners and directors of human services. It serves a purely advisory role. We are trying to make some champions of this idea, and it's stuff is complex and nuanced. So trying to build up some champions to take this idea to folks that they know and share it, and more importantly, tell them on the floor of the legislature at the last minute, you're reading that, it's all completely wrong. Here's how you actually should read it. And then they also provide us a lot of help with communication. How do we present this? How do we make this useful and actionable? Here's our general process. First, we assemble stakeholders. For mental health, there are a lot of folks that are delivering services and a lot of folks that are paying for it. So we work with the agencies, of course, DHS, MDH, DPS, and some other groups. Counties, we've assembled a group of counties to serve as providers of context and information and supply us with some work that they're doing and some needs that they see. For this initiative, we work with Hennepin, Dakota, Otter Tail, and Olmsted County. In corrections, we had about 25 counties that we relied on to gather data, and they provide a lot of that data. They also connect us with providers and clients and stakeholders and associations and foundations that are in this space to try and talk about the whole system. The first step is in the process is to inventory the program. What are we doing? I mentioned we have a full inventory on our website. They're kind of hard to print, and I am afraid I'm going to get yelled at. Stop printing by the state once they realize printing color. No, don't color. So these are available on our website, and I welcome you to check it out. We'll talk about that just a little bit more in a bit. Gather costs, hard to do. There's one in mental health. We're trying to develop the average cost. There is no such thing as the average client in mental health. And it's very hard to say how long a client may need services. And they may need them into perpetuity. But we try and come up with an average treatment cost, and as well as where do those funding streams come from. State sources, federal sources, county, so on and so forth. You get a sense of what does an average, I know it's afraid to say, but what does an average treatment regimen look like and cost? We run our model. This is a statistical model that comes out of Washington State Institute of Public Policy. Really interesting group out in Washington State. They have a group of about 15 to 20 researchers. All they do is effectiveness research. So they look at the rigorous evidence, medical trials, randomized controlled trials, and quasi-experimental designs, and evaluate if they're good studies, and if they are, what are the impacts on various outcomes. I've never seen actually anything else like it in state government. The legislature funds this and asks them every time a bill comes out to say how effective that may be. And, if possible, give a benefit cost analysis for it. They make all of their information readily available online. Not the model, but all the research they do is out there. So WISA.wa.gov, tremendous resource to kind of get a nice idea of the services that are offered. I'll talk a little bit more about the model in just a little bit. And let me stop here too. If you have any questions, just stop me. It's not going to bother me at all. And then we present findings. So we go out to legislators and share this. We have committee meetings last week, this week, and next week to share it with various Senate and House committees, bringing it to counties. I was in Olmsted this morning talking to a bunch of their commissioners about service offerings and what we can do and where are some levers we can pull. We work with associations and researchers and providers to try and share with that. Absolutely.
For gathering costs, what is scope is it? Just cost of the state, or is it also cost provider, individual?
Yeah. So in scope for us in our mind, and it varies a little bit from programmatic area to programmatic area, but we view the cost to anybody in the state. So we're looking at state costs, we're looking at county costs. When we do the benefit cost analyses, we ignore both the benefits and the costs associated with federal contributions. We acknowledge it and it's in the report, but that's not in our benefit cost ratio. Frankly, everybody takes those dollars and but when we do this as well, we use a proxy of an individual medical system. Just because that's the easiest way to think about it. There are all different types of insurance providers. A lot of that data we can't get to, but we can get to the public assistance dollars. So this is our inventory that I mentioned. Essentially, it's a universe of services. So we wanted to be able to put in one centralized place for anyone that wants to look at it. What are the services that we're offering, and how effective are those services according to the rigorous research? This is just a snippet of the whole thing that we talk about service to practice. What are the outcomes? What's the treatment look like? What's the average duration, frequency, intensity? And then really, this is our most important element, I think, and that is the impact on the outcome. So what we've done, and I think many of you will be familiar with this, but there are some clearinghouses out there put together by the National Institute of Justice and SAMHSA, the Substance Abuse and Mental Health Services Administration, that they look at the rigorous research, ascertain its quality, and then are able to say this service is, and combine it with all the other research that's like, they're able to say this is an effective service, this is a promising service, this is a service that doesn't have any research base or is not effective. So we dove into those clearinghouses. We also reviewed a lot of the literature ourselves. Some of the stuff isn't in the clearinghouses, so we did some of that work as well. But came up with some groupings. Grouping for services. The top level is proven effective. These are services that multiple rigorous studies have shown to be effective. And when I say rigorous studies, there are many types of rigorous studies. But what we're looking for is an experimental or quasi-experimental design. So a medical trial. You have a treatment group, you have a control group. They're alike in every other way, except the treatment group got mobile crisis, and the control group got treatment as usual. If we have this sort of design, as many of you know, we can say that there's a causal impact to the services, that mobile crisis cause changes in outcomes like hospitalization, employment, psychiatric symptoms, wellness, global functioning. So that's what we're looking for. We're going to have to multiple of those studies. Promising, we're looking for, we found at least one study. Often in mental health, the sample sizes are a little small. Maybe there's 40, maybe there's 60, maybe there's 8 people in a trial. So maybe we see good outcomes, but we could use some more data here or more robust The next level down is theory-based. These are services where there may be rigorous evidence, and there likely is local evidence that exists in a logic model to suggest this service is working, but we don't have that treatment and control group style research available just yet. Or maybe there is that, but there are some threats to validity, and we're just not quite confident. We consider this a neutral designation. A lot of times we get new innovative services in here that just haven't had the time yet to be studied. Maybe the studies in process. Neutral designation. Urgent care for adult mental health is actually a good example of this. This is something that more and more counties are starting to pick up. It's essentially triage, specifically for individuals that are having a crisis or have mental illness or substance abuse, or have a substance abuse disorder. The next level down would be no effect. And we did actually find some of these in corrections. But when we inventoried the services, we had 39 services here in Minnesota that we found in the care continuum for adults. We didn't actually find anything where the research says that the effect, there is no effect on outcomes. There's no positive effect on outcomes. It's a great thing. That means that the legislature and the agencies and the counties and the providers are using evidence-based practices. And when something is running counter to those practices and maybe counterproductive, they're getting rid of that service. That's a really great finding. We didn't find that in corrections. We found a couple services that have no effect or negative effect. And we found in substance use disorder, we already know that there will be a couple that have no effect or negative effect. The last is the category of services. And this is speaking to kind of the care continuum, and we'll talk about this in a little bit. These tend to be settings where a lot of things could happen. So in an acute care hospital inpatient treatment, you could get cognitive behavioral therapy, you could get medication management, you could get a myriad of services that are offered. But it's going to be based on client need. So every client is going to get a little bit different services. And so we categorize these in kind of a blanket area just so that we have a full continuum of care. We versus our inventory, we tried to break down just these lower parts. Oh, you're actually fine. Tried to break it down in these lowest parts, but it was very clear to the inventory people, like, where's inpatient treatment? You're missing something completely big. So we included these values. The inventory is also going to talk about what outcomes the research speaks to, so hospitalization, employment, homelessness, and other areas, psychiatric symptoms that the research tells us we're seeing an impact. It also includes a little bit about where in the system this occurs, as well as some of the sources for the research. So headline findings from the inventory, as I alluded to, we had 39 services on there. 23 of them were proven effective or promising. In other jurisdictions, I mentioned we're one of 24 states doing this. We found this is a pretty high ratio. Minnesota has a reputation for using evidence-based. In fact, 2 weeks ago, Pew came out with a study, Pew Charitable Trust came out with a study that said that Minnesota is in the top 5 in use of evidence-based practices. They're leading the way, with 5 states leading the way in the use of evidence-based practices to guide investments and decision-making. I think we're number 3. So there is this reputation in Minnesota, and I think it's maybe a self-fulfilling reputation where we say, we use evidence, so we better use evidence in this situation. We believe that Minnesotans are the best at this, and so I'm happy with that reputation because we can play into it and say that we should be using more evidence. 6 of them were theory-based. 10 of them were not rated as they were heading. They represented a bunch of services. This inventory is a living document. We will continue to update it. We'll continue to add new research. We'll add services as they're made available, and as we see new innovative techniques being used. So the meat of this, though, I actually, to my surprise when we started this, I thought the meat was going to be the benefit cost analysis, and a lot of our work, and so I'll talk about that in a bit. But people are really interested in the inventory, so that was a little bit. Our end goal was to do benefit cost analysis. So we were able to look at a subset of the services in the inventory. So 39 services in the inventory. The benefit cost analysis, we needed a lot of data. Essentially, we needed Washington State, Institute of Public Policy, to do a meta-analysis. Meta-analyses is where you group all the studies together into an average effect on hospitalization, employment, so on and so forth. So we knew that qualification to be met, and so we were able to do a full benefit cost analysis on 7 services. Future years will add more to that as more become available. The other option is when we do local studies that have the necessary rigor, we can use those as well. We did that for corrections. We were unable to do that for mental health, but may be able to. So what is the benefit cost analysis? And this is on the 2-pager that you all have here. So most of you guys are going to be familiar with this, but $1 in, if you have a benefit cost ratio of $2, then $2 means $1 and you're going to get $2 in return. We're able to break this into 2 different buckets: the taxpayer bucket and the other societal benefit bucket. Taxpayers are things the governments do, whether it be hospitalizations, emergency room visits, through medical assistance, they're going to pay for that. Through other mechanisms, they're going to pay for some of their services, grant dollars, levy dollars, so on. Criminal justice costs, there's going to be government benefits associated with if an individual has more labor income, there's going to be more tax income. So we're going to monetize taxpayer benefit. Other societal benefit, primarily for mental health, is increased labor income. The benefits accrue with the participant. In some cases as well, we're going to have other societal benefits related to decreases in crime. If you have decreases in crime, government benefits through less arrests, court supervision, prison, other services. But also there are going to be avoided victims. So if we avoid a victimization, there are tangible costs, lost revenue or lost wages from a job, and some hospitalization costs could occur. And then there are intangible costs related to victimization itself. An individual harm, there is an intangible cost associated with that harm. So those are the 2 components. We break them out because often legislators want to see in what bucket that we're talking about.
And just to check, from this I'm inferring that you're assigning a dollar cost to the society benefits.
Yeah.
You're walking on that.
Yeah, so it's associated with, there's a lot of research about victimization and the costs associated with that, the intangible cost. So the tangible cost, direct value, right? Missed work, missed hospitalization, the research can tell us, give us an estimate of what that'll be. For intangible, there's actually a wide range of economic research on calculating these intangible benefits. The way that our research does this is they actually look at civil case payouts. So a judge can say the harm for an individual that had an assault, and there is an associated dollar value that the research points to. Other ways I know some people look at it as like willingness to pay, willingness to avoid an event, but ours is through the criminal system. So we can break those out as well. I know some states have chosen to ignore those, but we see one of the roles of the government is public safety, and so we think that those are warranted. So I'm going to go back a slide, but I just want to point out that the benefits from monetizing in mental health, there are only 3. There are hospitalizations, employment, and crime. We're unable to monetize things that are really important. Things like declines in psychiatric symptoms, staying in your home, wellness, happiness, homelessness, for example. We can't monetize, we can monetize some of the outcomes associated with homelessness, like it's harder to get a job, more likely to be hospitalized, there may be increased instances of crime, but not having a home is something that we can't monetize. So there are plenty of things we can't speak to in the dollar amount, but the research can speak to, say that we know that they're associated with positive outcomes. The report supports those outcomes. Number 2, and I think this is incredibly important, benefit cost analysis talks about cost effectiveness. This is an incredibly powerful tool to talk about how cost effective a service is. Government and the folks that vote in elected officials have a lot more interest besides cost effectiveness. We cannot speak to values in benefit cost analysis that are related to fairness or justice or equity or innovation. These are all things that we want as a society and in varying amounts, but cost effectiveness avoids that lens, and it also, you know, I love talking about bias, and one of the things we're doing by presenting these, and I'm trying to stay away from, is we're presenting a bias by doing this. We're affixing we're putting a lens on cost effectiveness. We're kind of raising up cost effectiveness to say it's very important. We're monetizing the outcome. There are other things that we got to consider when we're doing these public goods, these public services. So I love to share that, and I'm happy to talk about that. Yeah.
So you just know crime is one of the benefits for you to monetize. Since focus on that's more like the victims of crime than the perpetrators, we're able to look at both sides.
No, that's a really good point. Yeah. Going back quickly, I want to talk a little bit about the model and what the model is doing. So, and I'm happy to talk more about it if there is an interest. But essentially what Washington State has done is they've done a meta-analysis. They've put together all the pieces of research on a subject. It could be a couple pieces. You know, most of the time we try and get to 3 or 5 pieces. Or some like assertive community treatment, which is a modality, treatment modality where they provide intensive services to an individual that's having a crisis or is very close to inpatient treatment, and try and prevent that individual from getting into inpatient treatment, provide case management, wraparound services, care coordination in a really low caseload environment, so a very low number of individuals that are seen by an individual treatment provider. Intensive services, actually, and Wilder is one of the groups that does assertive community treatment. So that has 50 or 100 pieces of research on it. They combine all that research together and come up with an average effect size. And there's some more complexity involved in there, of course. But let's say they come up with an average effect size for cognitive behavioral therapy, a form of psychotherapy, where they kind of rework, think through actions and responses to actions. Then we see a decline in hospitalization of 8% in the literature. Our model, which is the difference between the treatment group and the control group in that medical trial, our model is then going to take this effect size, combine it with information about prevalence and cost, hospitalization, and other Minnesota unique aspects. We're going to combine it with that effect size, and we're going to come up with a monetizable benefit to a decline in hospitalization. So we'll see less hospitalization costs associated with medical assistance. We'll see fewer ER visits, and we can assign a value to that. That's going to be over the cost. So that is the average cost to provide one treatment regimen here in Minnesota. Now, some of you in mental health know that there's average treatment regimen 1 and 2 treatments to last forever. So we looked at just 1 year. 1 year of cost, 1 year of benefits in all situations except one option. So for the 7 services we examined, yeah, go ahead. Yeah.
One question is, have you thought of where I used to work, we used integrated cost benefit cost analysis, the original cost effectiveness analysis, which just looks at what the cost solutions that outcomes. Have you ever done that sort of analysis? And you would because you might think that it's sometimes hard to interpret the benefit piece. Yeah. But if you look at it's like hospital visits, something like that, sometimes that can also be
Completely agree. Yeah, that's a great way to do it. And it's, to some extent, it's the step before you monetize, right?
Exactly.
And so in the full report, one of the things we do is talk about the cost of providing the service and the outcomes that we may anticipate. So I think it would get to that cost effectiveness. But that's a great point, especially for things we can't monetize. We do this, we see a 10% improvement in global functioning. I mean, we could never improve that, but man, that's a valuable thing that somebody's able to function better. Great point. 7 services all have positive benefits. That means that we didn't see harm. For a service, there was some improvement in some monetizable outcome. 6 and 7 also had benefits, total benefits that exceeded the cost. Again, we just looked at 3, hospitalization, employment, and crime. That's what we're able to do. There's a range of things that are valuable that we want more of, but didn't affix the monetary value. So on the back page of the report, we have some. So I mentioned the 1-year frame of benefits and costs. That is associated with this top grouping here. And then there was one that was a little different, and I'll talk about that. For the top grouping, essentially what we saw in mental illness is that either we didn't have the research or there was no persistence once the service ended. So the benefits stopped once the individual stopped receiving the treatment itself, or the research just wasn't long enough to say whether there was persistence. So 1-year benefits, 1-year costs are reflected here. Working off this top example, mobile crisis, I mentioned it a couple times before, but mobile crisis is a service offered by counties with state partially funds, where an individual or their family, if a crisis event is occurring, you can make a phone call to a hotline available soon, hopefully 24/7 across the state. They talk to you, and if need be, they send out a trained team to help you in your crisis event. Talk to you about the services that are available. If need be, they take you to stabilization and make other healthcare services available. This is instead of doing what typically would happen in the past of having a police response. So somebody calls the cops, and the cops are working with the individual, or a visit to the emergency room. Those are the 2 outcomes that we used to see often for mobile crisis, or somebody wouldn't get connected at all to the services they need. So in this situation, our benefits, monetizable benefits, minus our costs for that year is $1,280 for a unit. And a benefit cost ratio is $3.90 to $1.80 at 3.90 cents return. Taxpayer benefits are $1.20. And other benefits are $2.70. In this case, taxpayer benefits are associated with hospitalizations and declines in crime. Other societal benefits are related to declines in crime as well. That research wasn't available to speak to employment. Now, one thing I want to add here, and I kind of had in the background, but I think is really important to lay out explicitly, is that we're looking at national data. We're looking at data from across the nation. Minnesota management budget is not going into the field and evaluating mobile crisis. We're not setting the treatment and control group in Minnesota and following that treatment group for 3 to 5 years. Instead, we're relying on research from across the country. Implicit in there is an assumption that we're going to see the same effects here as we had in that research phase. It's a big assumption. But that assumption is important because it allows us to leverage hundreds of pieces of academic literature that they can see. And so while we like to make that really clear, what would be the optimal situations if we could evaluate everything here in Minnesota? I think as analysts we would love that. But knowing about cost and feasibility, I think right now is our best bet. So in total, benefits range from 80 cents to $3.90 in the things that we can monetize, except for cognitive behavioral therapy. We looked at cognitive behavioral therapy for 3 different treatment modalities: adult anxiety, PTSD, and adult depression. The research on cognitive behavioral therapy is really well fleshed out. We know that on average there is a decline in the lifetime persistence of conditions, prevalence and persistence. There's a lifetime decline in the prevalence of conditions, meaning the therapy has a persistent impact. So an individual goes through a treatment regimen, let's say 52 weeks, twice a week, cognitive behavioral therapy. After that time, they're going to see on average benefits continue to accumulate throughout their lifetime. So these are lifetime benefits associated with cognitive behavioral therapy. They range from $30.80 to $66 in benefits. It's in net present value too for the long-term term. Now,
Can I ask a question?
absolutely.
So, did you just look at cognitive behavioral therapy, or did you look at other things?
Yeah, so we looked at cognitive behavioral therapy. That was what was available to us. In our inventory, we looked at other types of therapy, like DBT. We know that it has a proven effective literature based. We just didn't have the meta-analyses available to do the full cost analysis. Yeah, that's one of the weaknesses of this. We're stuck on the things that we studied a lot.
So cognitive behavioral therapy is there not because it's the best therapy, but it's the study.
Absolutely. So we talked about cost effectiveness, but when we did this report, there's a lot of context and other things that are important. Most of these things are probably not going to be surprising to folks that are invested in the mental health system in Minnesota. The first is that there remain gaps in service availability. There's a lot more need and a lot more demand than we have services available. Department of Human Services did a study in 2014, and they re-released it again in 2015 with some additional data about the needs from county to county. They surveyed counties and they said, for you county, is there more or less supply than demand in your county? And so there's a great list out there that DHS has put together of all the gaps in the system, and I very much recommend you check that out. Department of Human Services Adult Mental Health Grant Report 2015. Yeah.
I need to find service. Are you talking about personnel? Are you talking about the actual program? Are you talking about the physical facility in order for someone to be able to walk in?
Yeah. So we think of service as an individual treatment modality. We use the word service. Program sometimes is used. We use the word service because that's how the legislature thinks about funding these things. Procedure code would also be something, sort of community treatment. You bill for that individual. Psychotherapy would be a service, so that would encompass a lot. We also do include the settings, but generally the research, like inpatient, but generally the research is down at the individual program treatment service. So research is at mobile crisis. So that's how we define a service.
Describe a little bit of the mobile crisis, what the patient care for adult mental health. They both talk about emergency care.
The urgent care for adult mental health. So this is where I don't have a clinical background. So if someone else is doing a clinical background, I'm very willing to speak for it. Otherwise, I can stumble in my way through it. From my understanding, it's about two different, it's about intensity a little bit. For mobile crisis, they're going to dispatch, one, there's a call line that you can call, and they're going to be trained professionals on the call line that can help you. Two, if need be, they're going to dispatch trained professionals that can help you. Whereas, from my understanding, urgent care, you can go to a physical location. This may be, I think one of the examples I saw is it was an emergency room, but there was a special area, waiting room and entrance, for individuals going through a mental crisis or that had mental illness and could seek services directly for that without going to an emergency room or going to a typical urgent care. They're staffed up with professionals ready to handle these situations and have better training. If there are any clinicians in the room and I'm wrong, please tell me. Or one. So I think it's mostly around intensity. And this one, I couldn't find any research that yet has studied this on that medical trial RCT. Gaps in availability. We also saw a lot of variance between county to county, not surprising. Especially in rural areas, it's very difficult to provide services when you have a huge geographic area and not a lot of density of providers or many individuals that need help in a kind of a dense area like you would in Hennepin County or Ramsey County or other counties that are a little more dense. Also, counties choose how much of their tax levy, of their tax dollars, they're able to or decide to pay for mental health services. So we do see some variance as well in how much counties are paying for. Now, more expensive in rural areas to provide services as well because economies of scale, frankly. And space. I mean, wide distances some of these providers are traversing to offer services. In the report, we highlight some of those differences, both in need and availability. And in workforce, too. I mean, that's a big part of the gap for rural Minnesota. Number two, some services we found are not implemented with Fidelity, the model. Fidelity means that we're not following the research model as it stands. This could be for many reasons, but if we don't follow that research model, we're not going to see the outcomes that we would anticipate if the research model is followed. That's an important caveat, and we could also get into a huge discussion about culturally specific services and whether fidelity is appropriate in some situations. I'm happy to talk about that, but I'll wait until we do that. The final thing is that a lot of our spending happens at the end of the continuum. Inpatient treatment is very, very expensive and intensive. We have a lot of services here in basic clinical, community services, and support. This is also where most of the research goes to, because randomized controlled trial is something that the medical field has been doing for a long time. And so they, when they're offering their services, will often do this. We have some randomized controlled trials in quasi-experimental here, less at the beginning of the continuum. But we know, and research tells us, although we could certainly use more, that prevention, early intervention may improve outcomes and be more cost-effective and could relieve some of the tension back here. But at the end of the day, we need to meet clients where they are, wherever they are. And so we need this to
we've often said appreciate right? Have you broken the between like so and different regions to see how
Yeah, so when we did this process, we worked individually with counties. So we collected data on their costs and offerings and tried to aggregate up. But a lot of the data sources we had available to us, we were the overall state average, and so no, we didn't break down into a regional aspect. I think it'd be possible. It would just be a little more time. Yeah, I mean, it could just be an immense variation in intensity, let alone distance, let alone the other factors that are involved. Yeah, so unmet need in mental health is tough, simply because there's a lot of folks where they don't come into a clinician to say that they have the need. You know, it's sometimes very difficult to identify it, particularly early in that continuum. So what we have right now available to us, this is opposed to like corrections. We have a great sense of unmet need there because we keep really close track of folks that are on supervision and the services they need. Just the nature of the piece with corrections. Mental health, we do have information from DHS on what counties report as needs. And in general, in the DHS report, there are things, a lot of the services that we see here that are evidence-based have needs of 70% of counties say they have unmet needs, 80, 90, 95% of counties. For inpatient treatment, it's 96% of counties have unmet needs. For mobile crisis, 90% of counties have unmet needs, on down the list. So it's tough to get to rely on surveys and anecdotes as opposed to the stuff.
Yeah. One of the doing sort of same analysis for integrated services, mental health, and preventive services. And that's a way to tackle that. People young students themselves, they're not letting the others. And we are saying both together. It's great to tackle that.
And in the report, we highlight some of the unmet needs that we found through anecdotes. Yeah.
Looking at the continuum of care here and understanding the challenges that you have in evaluating sources of funding. You know, when a health clinic, what let me speak to evaluating the continuum of services, they're looking at the three criteria, which is CNS, how can you extrapolate this data to apply it to private community model? You know, if you're talking about a critical access hospital like Montreal, who no longer use inpatient beds because more services on outpatient services, now they have space in order to provide mental health
alternatives do you apply in that aspect?
Yeah. So we get into a lot of trouble here with the different pockets issues. So an individual or a group saving money for promotion and maybe they're preventing inpatient services is not going to save from the same coffers as we would as we want. They're going to save money from an individual down the pipeline. So is your question more along the lines of that?
So when the county is looking at mental health services, you have a nonprofit like hospital. How can the county partner with that hospital to improve it? Right now, I feel like legislators should look at this and think that state responsibility without the right partners in order to address the gap.
Yeah, we certainly see it as a whole system. There are nonprofit providers or for-profit providers that are doing this. I think that there needs to be partnerships there. Our charge was to try and identify the state aspects of that, but part of what we're doing now is working into counties to talk about how they can contract and provide services that are going to meet the needs no matter whom they're contracting and providing with. So working with the private providers, working with other folks to fill the gaps. And maybe there's some opportunities there too. I think there is that different pockets issue where if a private provider saves the state or the county money, maybe there's some sort of for performance mechanism by which we can give money to those private or nonprofit providers to incent them to do that.
And how would be a wrong example in the hospital context? Something that could be in order to get
Yeah, that's a really great question. I don't know if I have a great answer to that, but I would love to talk about it more.
Well, it's also another perspective that from the private sector, the incentive has pretty good reason. In the sense that if you have less patients, you have less revenue. So you don't have a really, you may have a perverted incentive in the private sector.
in the hospital patients,
Yeah.
clinical stuff, but the opposite.
It would be you want people to come
Yeah.
It's weird.
Yeah. I mean, for mental health services, though, if we provide a service, often that service is, the individual isn't going to be cured of mental illness. You know, these are persistent services, and maybe we can have a service where we have continually offering of that service. They're getting arms or case management on a very ongoing long basis, and that's saving us money from maybe an inpatient outcome instead, because we have those services that a provider or an HMO is providing, and an HMO, to see the benefits, one, you have better patient outcomes. I know that they're very interested in that. But two, they may not have inpatient costs down the line. They're going to be in excesses of what we see for case management or arms. But are you from Minnesota?
Mm-hmm.
Where are you at?
Yeah, I work for the hospital.
Oh,
But I also serve on the board of directors.
yeah.
And so evaluating all of our funding sources and looking at where is the unmet need, especially in communities of color. When we talk about that, it's not just addressing the area.
Yeah.
It is addressing areas of low income. And we see that, to your point, if someone is caught early, they need to be help, if they need to be help, they need to be insurance.
Yeah.
And the health plan has a benefit to it.
Mm-hmm.
How do we convince Blue Cross Blue Shield that there is a benefit to that?
Yeah.
And then how do we build out the spaces in order to provide those kind of services?
I'd love to talk more about that. I don't know nearly enough. And that's stuff. Maybe we can connect after. Yeah.
I'm with Hennepin County.
Yeah.
And I know that the county has done a couple projects similar to this, and one of them that I had a very minor role on, so I'm not the lead, but in my role was about the homeless population.
Yeah.
And what they did is not necessarily look at the whole homeless, but they say, you are the biggest users of our homeless shelters, so that they take the biggest users of the, and it could be like mental health. Anyway, so they said, what is a intervention we can do and see if the cost to society, the cost that you have talked about all the discussion, drop. And fortunately, they yeah. So I bring up mostly just to see if you've heard of the studies that Henry County has done.
I have heard of that study.
Yeah.
Okay. And that's one of the things that where I think this model all of a sudden becomes really, really powerful is where we have this information about, you know, best practices and evidence and standardized formats, and we talk about what is best practices across the nation, but then to combine that with local research, local context, local information, you can really target it and say, here's what we know is best practice, here's what we know about our client population and where the need is, and whether that be general need or need among specific populations, socioeconomic, racial, ethnic populations. Here's what we know about our people. Now let's take these best practices and apply them and tailor them to folks that actually need it. One of the things that we are not able to speak a lot about are culturally specific services, because many of those culturally specific services have not been evaluated yet in the way that we need. But we know that there's a lot of research out there to suggest how we maybe can tweak best practices from SAMHSA or other services to fit those local populations. And eventually we will be able to evaluate them. One of the ones that comes to mind is they use cognitive behavioral therapy for offenders. Thinking for a change is the dominant paradigm. We know this is a proven effective practice. They started doing this, and there were some clinicians and treatment providers that were offering it, and they didn't think it was working that well for women. And so they took thinking for a change in cognitive behavioral therapy, tweaked it to something called Moving On, and then the Department of Corrections recently actually did an evaluation and found that this was a very effective service, and it was more effective than if they gave thinking for a change for to females. And so that's kind of the process. You see these clinicians that have great expertise on their population. They're able to take an evidence-based practice, tweak it, and then maybe eventually we study that as well and reflect on that. Yeah.
Doing presentations for the
Yeah, there's a couple common themes. One, the easy thing about this is that it's bipartisan. The findings suggest that if we use evidence-based practices, we're going to see improvement in outcomes that tends generally to speak to Democratic legislators, and not always, I'm super generalizing, but whereas we see some legislators more interested in cost effectiveness than the the fact that we're going to increase some tax dollars, though everyone has an interest in increasing services. So those are two things that we tend to be common themes. One of them, I think there's a little bit of disbelief that all the services we found were either from proven effective or no theory-based. And that's where I think I need to do a better job of communicating with clinicians and agencies have been using evidence for a long time. That these are practices that they're doing because they want to see better outcomes for their clients. And so that's one thing that we're working on is, no, not everything is going to work, but in mental health, we've seen a lot of positive things. The other one is need, articulating needs. That question comes out a lot.
Is there any, like, early community, so, like,
That's something we can back that is dementia, right? We get in the fight of complexity versus prevention in a way that we can understand. And so there are many situations where that comes up, and all you are very familiar with those situations. But we get, oh, well, we'll just put everything in cognitive behavioral therapy. And so we have to talk a lot about, you need to meet the client where they are. Cognitive behavioral therapy is only going to have the outcomes that we anticipate for folks that need cognitive behavioral therapy. It's not going to have an impact if somebody doesn't need that therapy. In fact, it might have harmful impacts. And so we fight against those trade-offs, but that's something that we get into that. I wouldn't say anything on our list on the 7 are interchangeable, and many times they work together.
Yeah, I think a little bit about that. Especially mental health. Putting down the benefits for the state, you see to the reduce the reasons that you mentioned.
Yeah.
I mean, you can reduce hospitalization costs, but 2 phases of those.
Yeah.
And then next is part of the money comes from the federal and state, and sometimes the regions are a little more skeptical, say, well, we got federal money, they're not paying anything. So you have to argue in favor of all the societal benefits, unmet needs, it doesn't, it's kind of a minimize the parties and the local view, point of view of federal money, really fair. That's something that we try to find.
And we're able to break it out on average, but like at one, we were using a simplified proxy of just medical assistance. There's a lot of people on private insurance and other forms of pay. But even inside medical assistance, depending on who you are, the state pays a different percentage, and the percentage can actually be wildly different. And so, I mean, if you're a child or a mother with a kid, the percentage on what the state's going to pay is going to be different than if you're a single adult. And so we've just simplified it to here is on average the state amount and the federal amount. And we break out and say what that federal amount is, and we also talk about the benefits that accrue to the feds, not to us, through like declines in hospitalization, or they get a lot of the gains in tax income increases. But it's really hard. One of the exercises we went through at DHS, which proved way more complicated than I had any idea it was going to be, is we took our inventory and then bumped it up against procedure codes, so how things are billed for. So fee for service, I'm going to get into these here, sorry. Right now, too. It's fee for service, so one form of payment by the state, and then there's managed care organizations. So we're able to break out, like, from what buckets are we paying for each procedure code. Assertive community treatment, here is the total amount we're spending in grants, service, managed code, and here and where in the budget those things came from. We did that. I was going to take a couple days, take 8 months. And really, like, even the procedure codes are not low enough. Like, the lowest we can get is like psychotherapy, and there are 1,000 different types of psychotherapy. So we did provide that and make that available. The fiscal analysts and legislators really love that stuff. Got some pushes for that. But it also shows the levers. By doing that, we can show how you could increase use of mobile grants. Grants are probably the most effective way here.
I wonder where we're going back to your slide that has the cost benefit analysis, but 5 different categories. Sorry, going further. Yeah. So are we not going from your proven effective are people with that illness, mental health illness, to those at the bottom?
Yeah, so this is, yeah. So you're saying like the least severe or theory-based?
Well, we have an impact of the outcome.
Yeah.
Right? So it seems to me, and I could be wrong, but the way I see this is we're talking at the top here, proven effective are those that you're calling mobile crisis. So these are an instance where somebody's going up to somebody's house and trying to calm them down. That's very effective versus inpatient residential treatment. It suggests some more severe mental illness is not as effective in terms of benefits. But I'm just wondering, am I reading this wrong, or is that?
Yeah, so I would say this category of services doesn't have any data associated with it.
Right.
And it's because we're looking at multiple settings. This is a setting, and many services are inside of this setting. So we can't, it's hard to speak to whether there's effects because there's also, each client's going to get a little bit of different set of care. but I heard someone,
Yeah, I
right,
was
James?
just gonna say, it's important to note that what's being shown here
Yeah.
are, for examples of services, this is not exhaustive. So, this is really just a quick glance, so you can see the 40 potential impact on outcomes. But the inventory itself is much more robust given the number of services that are provided. So you might see another one does that is for those, that serve the population that is, more intensive, and it needs to be like a richest, we can take this out.
Yeah, there's
So
just,
that you can do for the impact on it. If that's helpful.
Yeah, but I'm just wondering if the impact on less severe illness is greater than the impact on more.
not always. So, it's just hard because it's this is a setting, and so like it tends to be these settings are often more intense patient profiles. Not always, they're outpatient settings. So we don't have evidence to suggest that all of these taken as disease are effective, because if you think about it too, like what will we compare it to, right? Like, what's our counterfactual? If we have an inpatient setting, there are no other there probably aren't many other like folks that we could do the analysis and compare to whether inpatient is working or not, because all the folks that need inpatient are in here, not all of them, many of them are in the inpatient setting, and so it's very tough for us to actually do the analysis. We try and break it into individual treatments when they're while in the future. I know that. I don't think that's helpful.
Given the time, I maybe will have time for one more question, and folks are, I think, usually welcome to stay for a little bit longer, but we also want to respect some time and let people know that they're looking to leave.
Thank you. I have a couple of copies of the inventory if you're interested.